We're going to take a look at acquired immunodeficiencies. Acquired immunodeficiencies are aberrations in the immune function. Over the past 20 to 30 years, you've probably heard of HIV and AIDS. This is probably the biggest acquired immunodeficiency that I can think of. There are some that are genetic or metabolic and some other factors, but the most common one would be the HIV or the AIDS. We're going to take a quick look at some of the other things that are not HIV and AIDS before we move on to those diseases. So the first one is malnutrition. Nutrition is needed for the immune system to function. If we have a lot of malnutrition, we see certain chronic diseases. Usually there's a low caloric intake and a protein deficiency. And as you know, everything in the immune system is made out of proteins, right? The complement factors are proteins, antibodies are proteins. So it's very important that you have those types of nutrients in order to have a properly functioning immune system. If somebody is malnourished, when we give them proper nutrition, it usually reverses those effects. Now, some of the things that the immune system needs include vitamin C, which is probably why the citrus fruits and things grow more in the winter during cold and flu season. Vitamin E, B6, A, vitamin D, folate, folic acid, iron, selenium, and zinc. So as you can see, a lot of those things come from our foods, and we would need those in order to have a healthy immune system. Another one type of issue we can have is a metabolic defect. One example of this is diabetes mellitus. With diabetes, we do see dysfunctions in chemotaxis and phagocytosis. We've got decreased T-cell proliferation. We've got an associated with the defective metabolism of glucose. Our neutrophils depend on sugar metabolism. So if our blood sugars are out of whack, our neutrophils are going to be too. We do have hyperglycemia. The neutrophils don't function as well there either. So in either direction, those neutrophils get a little fussy. And they did find that with diabetic mice, they're a lot more susceptible to staph infections, and that when they do have hyperglycemia, it does affect their immunity. We can also have genetic defects. We can have a directly associated, which would be a primary immunodeficiency, something you're born with, or an indirectly associated issue. This is where it affects the function of the biological system, but is not part of the immune system. Something that would be indirectly associated would be something like Down syndrome. They're very susceptible to certain infections. Their phagocyte function can be affected, and they can have a decrease in chemotaxis and phagocytosis. We can also have a genetic defect of the physical barrier of innate immunity. Something like cystic fibrosis. We see an increased thickness of the mucus secretion, and it makes them more susceptible to respiratory infections. And lastly, drugs in the environment. Certain anti-inflammatory drugs and immunosuppressive drugs, things like corticosteroids, cytotoxic agents, monoclonal antibodies, and other inhibitors can have profound effects on the immune system. So while they may be giving somebody a corticosteroid for inflammation, it does suppress the immune system as well, which can make you more susceptible to other types of infections. And then there's environmental issues, like having extreme age. If you're 100 years old, you're not going to fight off an infection as well as if you're younger. Ionizing radiation, being at a high altitude, a lot of UV light, or having chronic hypoxia or low oxygen. So this brings us to HIV or AIDS. The CDC says that there's greater than 1 million people living with HIV, and that 20% of them aren't even aware of that. Over 56,000 become infected every year, it's a pretty stable number, and 18,000 with AIDS die annually. In Africa, 60% of all cases of HIV, there are a lot of them in Africa, obviously, and half of them are women and children. And it's interesting, 25 million people have died of AIDS since 1981. That isn't even that long ago. So who's at risk for this type of infection? Well, the biggest classification of people that are getting infected are men who have sex with other men. Injection drug users, about 12%. And then heterosexual contact is about only 30%. HIV does cross mucosal borders, and blood transfusions or contact with body fluids seem to be the biggest way that this is transmitted from one person to the other. So let's look at this HIV virus. The HIV virus is known as lentivirus. In the HIV genome, we've got 3 structural genes, the GAG, the POL, and the ENV, and 6 regulatory genes. It's a single-stranded retrovirus that infects the CD4 helper cells. So I have a picture over here on the right-hand side, and you can see this HIV virus docking onto the CD4 cell. It fuses, and it actually uses, and we're going to go through this in more detail in a minute, it actually uses the DNA within our own CD4 helper cells to replicate itself inside of our white cells. Now this gets pretty tricky because our body still recognizes our white cells as white cells. It doesn't know all this is going on inside. It replicates itself, the cell bursts open and releases many, many copies of new HIV virus. This is why it's so tough to treat. You can't really treat something that's replicating inside of one of your own body cells. There's 2 types, HIV-1, HIV-2, and both of them can result in AIDS. So let's look at some of these proteins. The GAG gene encodes for a GAG protein, and this is cleaved into a P24, a matrix, a nucleocapsid, a P6, and a P2. Those are parts of the viral particle that stabilize the viral genome. Then there's a viral envelope that includes glycoprotein 120 and 41. The 120 is what binds to the CD4 on the cells. That's important to know. Then we've got these steps that I just talked about briefly, and we'll have it again on the next slide. But the first thing is it binds to the virus on the host cell with that glycoprotein 120. It attaches to the cell, and G41 protein penetrates the cell membrane. This is where the virus then enters the cell. It releases all of its RNA and its enzymes. Through the process of reverse transcriptase, it converts RNA into viral DNA using some of that cell's nuclear material. So with this, there's viral reactivation, and there is almost a burst where it does release more of those HIV types of viruses. So here we have the fusion of the HIV to the surface with the glycoprotein 120. You can see that here. HIV, the RNA, reverse transcriptase, integrase, and other viral proteins enter the host cell. Okay, the viral RNA and reverse transcriptase actually use the host DNA to create new RNA. The new RNA is used as a genomic RNA to make viral proteins. The new RNA proteins move to the cell surface and form a new immature HIV. The virus matures by protease releasing individual HIV proteins. So you can see through this whole process, using our cells within our body, it creates new viruses. Now, like I said, it's tricky because it's happening inside our cells, so our body doesn't fight off our own cells. So that's where things get makes it very difficult to treat. So in order to find out if somebody has HIV, we test for HIV antibodies. We can detect them in the blood, the mucosa, and other body fluids, and they usually occur within 1 to 3 months after exposure. We call this the window period. It plays a role in antibody-dependent cellular cytotoxicity, complement activation, and in direct neutralizing. The early antibody responses target the GAG proteins, example P24, and late antibody responses to viral envelope and some regulatory proteins. We try to limit viral replication, so we try to keep the virus in check during those asymptomatic stages, but those antibodies tend to mutate rapidly and make it very difficult. So the eclipse phase is what's first. This is the 7 to 10 days after infection. It's not very easily detected. Virally infected cells and free virus arrive at the lymph nodes. The CD4 cells get infected, and the virus spreads rapidly. Okay, so usually within 20 days of infection, we can start to see this elevate. The highest viremia CD4 levels are low, but later return to normal. The viral escape from the immune system, we have reservoirs of virus. So the CD4 T cells, monocytes, macrophages, dendritic cells, brain cells, and it causes persistent infection as well. We have infected cell depletion. Okay, so once all these CD4 cells are infected, it starts to deplete the amount of CD4 cells that we have because it destroys them. So once your CD4 cells, which are your helper cells, become more and more decreased, usually there's a 2-to-1 ratio of CD4 to CD8, Once the CD8 or suppressor cells become more elevated than the CD4 cells, we end up in an immunocompromised situation known as acquired immunodeficiency syndrome, or AIDS. So the symptoms of this are very asymptomatic at first. You don't know you have them. Then you're going to get some flu-like symptoms, headaches, nausea, sore throat, fever, diarrhea. An acute HIV syndrome can be mistaken for other infections and usually last a week to a month. Viremia is a very, very high virus, and it tends to spread, and this is where we see a rapid decrease in the number of CD4 cells. Next is clinical latency. This is where the immune response reduces the viral numbers. The virus is not totally eliminated. It remains in low numbers in the plasma and lymphoid tissues. Usually it can be pretty asymptomatic. CD4 cells might return to normal. Could last several years. Some remain asymptomatic, don't even know they have it. This is that 20% we talked about. The virus multiplies, destroys immune cells. There's a risk of opportunistic infections. We'll talk about those in a little bit. We can see oral candidiasis or thrush. That's a common opportunistic infection. We can see an increase in Kaposi sarcoma or lymphomas. Okay, if you've ever seen the movie Philadelphia with Tom Hanks, you remember him having these little marks all over his body. It's a type of skin cancer that only HIV patients get. So if a patient presents with that, the doctor is going to probably start testing for this. It also infects the central nervous system. So you can have a metabolic encephalopathy. There's an AIDS dementia complex that can happen. It can manifest itself years after HIV infection. So with the testing, usually there's a window period. So it varies from test to test. The antibody testing is usually about 30 days, while antigen testing has a shorter window of about 15 days. So if they test for the antigen, it's usually pretty soon after infection. After that, you develop the antibodies, and the antibodies will be tested for. Another common thing they do with HIV patients is test their CD4, CD8 counts. Now, this doesn't really test for HIV itself, but since HIV has such a profound impact on those CD4 T cells, if we keep track of their count, it kind of lends you to believe that they may or may not have crossed over to the AIDS classification. Once the CD4 helper cells are less than 200 per microliter, we define the patient as being an AIDS patient rather than an HIV patient. Normal CD4 T cell counts are between 500 and 1500, so less than 200 is pretty low. So we monitor those CD4 counts to monitor antiviral therapy effectiveness and to anticipate opportunistic infections. Once those start getting pretty low, we probably start seeing some infections that are going to start to occur. So usually you can see we have about a 2-to-1 CD4 T cell to CD8 T cell. Remember the T4 helpers, CD8 are suppressors. So once you start to see the CD8s become higher than the CD4, now you've got more suppression than helping, and you're in an immunodeficiency type of syndrome state. So we look for these antibodies. They develop the anti-HIV antibody within about a month or two after exposure. Almost 100% that are infected show antibodies 3 months after infection, and the detectable production of antibodies to HIV is called seroconversion. So you seroconvert over that period of time. We can do rapid screening tests and confirmatory tests. Usually the screening test is ELISA. So this is an enzyme-linked immunosorbent assay. This has a high sensitivity and high specificity for HIV. Early screening can detect those antibodies against the viral lysates from HIV-1 viruses. So there's increased specificity and sensitivity, and we can detect anti-HIV of different isotypes as well. Once we find out somebody is HIV positive first by ELISA, we send them out for an absolute confirmation test by using Western Blot. Western Blot evaluates the presence of antibodies to greater than one viral component. Now, the components are separated electrophoretically by molecular weight and are transferred to nitrocellulose. They add the patient's serum, which are allowed to react, and after washing, an enzyme-labeled anti-human antibody is added. It reacts with the patient antibody, and we visualize a substrate. So we can see all the different proteins on this HIV virus down in the bottom. When we put them through the electrophoresis, they separate out, and if they fall into this pattern, we can confirm the fact that it actually is HIV. And that concludes our section on acquired immunodeficiency syndromes.